Okay, so thank you for being here. This presentation is a little bit different than the usual presentations that you have listened so far, because this presentation is about what can be happening in the future, about future treatment of mood disorders. I remember it was 30 years ago when I started to work in psychiatry. And there were the new treatments, the new serotonin reuptake inhibitors. Well, the point is that after 30 years, indeed, we did not have many new drugs. So, first the tricyclics in the 50s, then the SSRIs and SNRIs later, and then for about 30 years, we didn't have much new. But now we are in a moment, in a situation where there are many new antidepressants indeed. Some are already in the market. Probably you are aware that the new ketamine-like antidepressants are approved in many countries, but ketamine usually is administered intravenously and can be a problem. Now there is a new intranasal esketamine that is a little bit better, but we will discuss this a little bit more later. Very recently, there are the neurosteroid, allopregnanolone, brexanolone, that is a new compound that can be very interesting. And these are the new compounds that are in the market. But what will I tell you today, what will I show you today, are the compounds that will arrive in the market in 2, 3, 4, 5 years, or probably a little bit later, so that you can be informed on what is happening in the discovery of new antidepressants. Why we need new antidepressants? We need new antidepressants because the antidepressants that we have at present are not as effective as we would like them to be. Um, First point is the efficacy. The efficacy of the present antidepressants, as you know, is complete in one-third of patients. Partially in another third, and no efficacy at all in another third of patients. This is why we have to change, make augmentations, combinations, and so on. And then there is the issue of tolerability. Each of us is familiar with the fact that not all antidepressants are perfectly tolerable. Some of them give problems indeed, some serious problems, some less serious problems, but indeed they are not very well tolerable. And the last, but probably one of the most important points is the speed of response. Many antidepressants, they take 2, 3 weeks to work. This is why we were so excited when ketamine came out. So let's look which are the new antidepressants of the future that can probably change all these unmet needs that we have now. Let's start with this one, EV11. This is a selective antagonist of NMDA receptor. You will listen a lot about NMDA receptors because they're the one that came much famous for the ketamine story about 15 years ago. After ketamine, a lot of people is trying to find new compounds that somehow modulate the NMDA receptors, and this is one of them. In theory, this one is very promising because it's working on the tyrannin pathway, and it seems that this could be neuroprotective and very useful at a cellular level. What was very interesting is that animal study gave very positive results of a rapid and sustained effect after one single administration. This is why the company was very enthusiastic about this product. But the point is that the trials that have been performed so far are not very positive. Probably this is due to the fact that the dose is an issue. Probably only higher doses can be useful because they really modulate the NMDA receptor. In any case, EV11 for chloroquine could be a possible future antidepressant, but at present is not the most promising. This, on the other hand, is one of the most promising new treatments that we have now. This is, it was called AXS05 and is a combination of dextromethorphan and bupropion. You, of course, will know very well bupropion, dopaminergic antidepressants, and dextromethorphan that has not been used in psychiatry till now. But the combination of the two, as also reported in the Stahl book, is particularly interesting. This is one of the most promising new antidepressants that we have, and that probably you will have soon also in this country. It has been approved, in fact, by FDA last year. Why is so interesting? Well, the combination of the two compounds give effects that are different from the effects of each of them. Why? Dextromethorphan is a non-selective antagonist of an NMDA. So again, we are talking about the glutamate pathway. But also the sigma-1, that is another very interesting receptor that can modulate the cognitive performance and so on. And other effects also on the monoamine transporters. And bupropion, you know what it is, reuptake inhibitors of dopamine and some noradrenaline. But the point is that bupropion helps dextromethorphan not to be metabolized by the liver, therefore changing the pharmacokinetic of the dextromethorphan, making it more stable in the blood. At a clinical level, results are very, very, very positive. We have a very rapid antidepressant effect since week 1, and we are talking of a compound that is not ketamine. So a combination of bupropion and dextromethorphan can have a benefit in terms of antidepressant efficacy even as week 1. And the benefit lasts more than 1 month at least. The studies so far arrive at 3 months. That is a sufficient amount to consider the depressive episodes concluded. It has been studied also in treatment-resistant depression that is usually very difficult to treat. And this combination was useful also in treatment-resistant depression, with effects that can last up to 1 year. Also, the relapse is not present. And what's very interesting, that there was also an enhancement of cognitive function. Usually, you know that many of our psychotropic treatments, they may have a variable degree of cognitive impairment, while for this combination, we have a cognitive function enhancement. And FDA has approved it last year. Another compound, PH10. What is this PH10? This PH10 is a very different approach to antidepressant treatment because it is administered intranasally. It goes like esketamine. It goes in nasal chemosensory receptor and it modulates it. It is a neuroactive steroid that belongs to the group of pherines, and it is very nice to have this possible intranasal administration. It has not been very studied so much, but the initial results are very interesting. There is one randomized clinical trial that shows antidepressant effects as early as 1 week, again, like the combination of bupropion and dextromethorphan that we showed before. And it lasted for 2 months. Up to now, there is no clear evidence of suicide radiation, TRD, or bipolar disorder. It has still to be studied. But this is a very promising compound, and it is different from the mechanism of action that we had so far. I say again, like I told you at the beginning, we've been for more than 50 years with antidepressants that only modulate monoamines like noradrenaline, dopamine, and serotonin. Now we are starting to work with all different systems, an MDA, neurosteroids, and this, for example, is one nice example. Another compound that you are probably familiar with, you that heard in the last few years, is pimavanserin. Pimavanserin is even different from the compounds that we have seen so far. It has been studied and suggested as an atypical antipsychotic. Why atypical? because it goes only on the serotonin 2A and serotonin 2C. So there is no anti-dopaminergic effect. Of course, this is very interesting because we don't have all the usual side effects of dopamine modulators like traditional antipsychotics. It has been studied mainly in neurological diseases, Parkinson's disease, for example. Initially, it has been shown to be useful for hallucinations in Parkinson's disease. Later, it has been approved by FDA about this use, hallucinations and psychosis in Parkinson's disease. But later, it has been realized that it can be useful also as an antidepressant modulator. And this is why it's under study as a possible augmentation or combination in antidepressant treatment. So it is currently approved by FDA to treat psychosis in Parkinson's disease, as we said, is useful for depressive symptoms also in the short term, also during the first week. Again, we are talking about a rapid efficacy. It is useful as an adjunctive treatment for a series of symptoms that are not usually well targeted by other treatments. Impulsivity, irritability, anxiety, insomnia, and daytime sleepiness, of course, linked to insomnia, and sexual and psychosocial functioning and quality of life. Therefore, you can imagine pimavanserin probably not as a mainstream therapy, a drug alone therapy, but as a combination. When the antidepressant has a partial efficacy, we can modulate the clinical picture with pimavanserin. This is another kind of compound again, Prax 114. It is part of the neurosteroids, the one that you are very familiar that came out a couple of years ago, and it modulates the GABA A receptor as well. It is potentially interesting because it is supposed to have less side effects than the currently used neurosteroids. However, a strong antidepressant effect till now has not been demonstrated for this compound, even if it seems to have a benefit in perimenopausal, postmenopausal mood swings in women, even if the effect seems to be only when the drug is taken. After taking the drug, the benefit disappears. In any case, a marginal effect in a specific clinical situation could be there for Prax 114. And let's come to psilocybin. Psilocybin, as you probably know, is quite famous at present because a lot of groups are studying psilocybin. Is not a new compound, of course, is well known since many years, more than 50 years, even more. There are proofs that it has been used also in ancient times. All the hallucinogen plants have been used thousands of years ago. But in recent time, it has been used in the 60s and 70s in order to improve psychotherapy effectiveness. Because these kind of treatments, as you probably are familiar with, they change somehow the perception of time, the perception of the relation with the other. And therefore, this way you can open the patient to the psychotherapeutic relationship and it can improve its outcome. At present, psilocybin is currently studied in many disorders, major depression, obsessive compulsive disorder, but also some kind of dependencies. There is one group in the Imperial College in London that at present is doing a clinical trial. I have one collaborator working there, and the results are very interesting. But what is psilocybin? Psilocybin, of course, is a natural compound derived from plants that modulates serotonin 2A and serotonin 2B receptor. It is an hallucinogenic compound, of course. In many countries, psilocybin is considered not legal. The research that the world is doing now is to understand at which dose, for example. In the past, higher doses have been used. Now, the suggested dose is between 10 and 25 milligrams per day. Per day. But there is evidence also that psilocybin has a very interesting potential that you could use psilocybin only for one administration, and it seems that the benefit goes on for more than 6 months, one time only. And this could change the way we treat depression. This is based on evidence that we have so far, but it's based also on many studies that have been done in the last 20 years that suggest that psilocybin may also change a little bit the personality of the patient, increasing the openness and the attitude to relationship. About one third, half of the patients treated with psilocybin, they say that after 6 months or 1 year, they still feel better in terms of well-being compared to before. So could be also a frightening perspective because we are talking about a compound that at least potentially can change the personality of the patient for a long time. Of course, there is need of much studies on this, but the potential of an antidepressant that has a very quick efficacy, very quick, that can last for months after the administration, of course, is fascinating for us that are always frustrated with lack of efficacy, tolerability, and the problem that we have with current antidepressants. And it can be used, as we said at the beginning, together with psychotherapy. This is why the FDA a few years ago gave psilocybin the fast track of a breakthrough therapy. A lot of studies are ongoing now with psilocybin, and I think that in the next few years we may have a formal approval. Also because it's very interesting the possibility to use micro dosage of psilocybin, doses that are much below the 10 and 20 milligrams that are the standard, 1/10 or even less. These also are studied. Another positive aspect that you can pre-treat the patient with escitalopram before giving psilocybin, and this gives a relevant benefit because you reduce the side effect of psilocybin. Psilocybin can, of course, give to some patients dissociation, transient anxiety. This is obvious, in particular for people who is susceptible to this. And microdosing. Okay. Another compound, destromethadone, uh, REL 1017. This is another different again mechanism of action. Don't misunderstand the name. This is not methadone. This is not the methadone that we are using for heroin dependence. This is dextromethadone. And this change at the molecular level gives a relevant change also in the pharmacodynamic and the action of this compound. This compound has no opioid activity, but the interesting thing is that it has a non-competitive antagonist effect on NMDA receptor. So again, we are talking about NMDA, ketamine story. No opioid-like effect. It gives a benefit in plasticity in the medio prefrontal cortex of animals, so probably also in humans. And also for this compound, FDA gave a fast track of approval for adjunctive treatment in depression. Again, here the effect of antidepressant that you can observe is as early as the fourth day, something that we are not used with conventional antidepressants, and it keeps being there for at least 7 days. There is also benefit in cognitive and social functioning, anxiety, agitation, anger, irritability, and sleep quality. So, dextromethadone is another promising, I would consider it complementary therapy to antidepressants, not a substitution of antidepressants, like pimavanserin that we have seen before, more or less the same role, I would say in the future. Let's change again system, and now we talk about seltorexant. You heard about this in the previous presentation about anxiety disorder. This is another, again, different mechanism of action. And again, you see how many different mechanism of actions we are seeing. We were used to have usual monoamines, monoamine transporter blockers. Now you have seen many different mechanisms of action. This is very interesting because it's a selective agonist of orexin 2 receptor. Orexin is a very interesting molecule because it modulates sleep and wake functioning. If you block the orexin 2 receptor, you can modulate these aspects in the patient. And therefore, this seltorexant has a very interesting effect of normalizing sleep in major depression that are being already treated with antidepressants and the improving the antidepressant effect of the ongoing antidepressant treatment. Therefore, we have another example of a compound that can be used to modulate partial efficacy, for example, of SSRIs. When SSRIs don't work well, we could add some seltorexant if we don't want to add, for example, a benzodiazepine, because we know benzodiazepine have the risk of tolerance, dependence, and so on. And this is different approach. Another system again, neurosteroid, zuranolone. Probably you are all familiar with the old, well, not so old, I showed you in the first slide, it is already approved, brexanolone for postmenopausal depression, but also for depression. Soon will come, I think, also in your country. Brexanolone and allopregnanolone are the same thing, of course, is two different names from the same compound. But the problem of brexanolone is that you can give it only intravenously, so it's not very practical. Zuranolone is solving this problem. You can administer zuranolone per os. So it would be wonderful to have a GABA A modulator, a neurosteroid that works, and you can give by tablets. Therefore, is more practical than intravenous brexanolone. The antidepressant effect has been demonstrated in 3 different randomized clinical trials. So I think there is no doubt that zuranolone is working. And what's very interesting is that the onset is very rapid. The onset is at day 3 until day 42, 45. So very long, even if not in all studies. The benefit is also on residual insomnia, and it is useful also in postpartum depression. And what is very interesting, it is useful also in bipolar depression. While, as you know, bipolar depression is very difficult to treat with conventional antidepressants because they don't work very well. So to have another option for bipolar depression is very interesting. So summarizing this part, we have a lot of new compounds for major depressive disorder, the ones that we have seen, with a different profile of efficacy. We will discuss a bit later. We have new compounds for treatment-resistant depression, bupropion and dextromethorphan, psilocybin, and dextromethadone. All of 3 are very interesting compounds for treatment-resistant depression. And then we have a series of compounds that can be used in different conditions that usually are difficult to treat, like postpartum depression, bipolar disorder, depression during Parkinson, depression during medical disorder like cancer or AIDS, infective disorders. In this slide, we can see a summary. This is what I usually like a lot, the personalized therapy. So how these different compounds that we have discussed today target what we want. They target in a different way. So, as you can see, mainly the NMDA antagonists work on cognitive aspects and mainly on antidepressants effects. Psilocybin has a very wide range of effects on negative emotionality, cognition, on agitation, and so on. The steroids and the serotonin 2A are more effective in the anxiety area, are more sedative treatments. So this table could help for the future when you will have these compounds in your country to choose which of them to prescribe for a specific patient. If the patient is more on the agitated profile in terms of symptomatology or more on the sedative or apathetic profile of symptomatology, you can use the NMDA receptor or the neurosteroids or the serotonin 2A modulators or the or the sultoric modulator. And conversely, of course, they don't have the same side effect profile. Some are more tolerable than others. Some impact on the gastrointestinal system, some impact on the sleeping system, and of course, each of them has its own, let's say, personality. But it's important for you, being a prescribing clinician, to know exactly which of them is impacting where. Don't worry about this data, that they will be published soon. So to summarize, the first compound, even if very promising at present, has no indication. I put none. While the REL 1017 is probably an adjunctive treatment to standard antidepressant. The dextromethorphan is very promising as monotherapy, both for depression and treatment-resistant depression. Psilocybin is extremely interesting as monotherapy for depression and treatment-resistant depression, monotherapy in other conditions, and psychotherapy-assisted psychotherapy-assisted psilocybin. Pimavanserin also could be a possible complementary therapy with for antidepressants. And zuranolone, that is one of the new neurosteroids, has this very interesting profile of benefit in bipolar depression that is always quite difficult to treat. Prax 114 is probably indicated for monotherapy in premenstrual, perimenopausal disorder, but still we have to be sure about that, as well as the intranasal pH10. We need more studies about them. And the orexin modulator is very interesting as an adjunctive treatment for major depression when there are sleep-related issues. In the paper, you will find also this graphical presentation of the compounds that we discussed that can be useful as a glance for you to understand which of the compounds is better from a cognitive profile, from a sleeping profile, and so on. But you will see in the paper. One of the last points about these compounds is how long have been studied. Psilocybin has been studied for as long as many years, as well as dextromethorphan. The other much less, in the range of few months or at least a few weeks for the less studied ones. This is why we need more studies for some of them. In the final part of the presentation, I will focus on even more new compound, or let's say less studied compound. In the family of psilocybin, there are other compounds. One of them is the so-called ayahuasca. Ayahuasca is again a compound that there are proofs that has been used since more than 1,000 years by religious practices and so on. because this compound give to the individual some kind of religiosity, contact with the universe, so something that you are familiar with, that is the modulation usually of the serotonin 2A receptors. So ayahuasca and psilocybin are not new. What is new is the use that we can use, that we can make of them as antidepressant. And therefore, ayahuasca received as well very relevant interest, is less studied compared to psilocybin, that I know is not yet in FDA approval plan, but probably I'm missing something, but I don't know that. It has a different mechanism of action, not only serotonin, it works also on the monoamine oxidase enzyme. Results indeed are very strong because the antidepressant effect of ayahuasca are really relevant if you look at the few studies that are there. Of course, it's not perfectly tolerated like psilocybin in terms of gastrointestinal problem, anxiety, and some other agitation symptoms that can happen. But ayahuasca is something to take in mind. In the group of NMDA modulators like ketamine, there is another one, rapastinel, that raised a lot of enthusiasm a few years ago because it can be administered orally, so you don't need intravenous administration and so on. Problem is that out of four studies, only one was positive, and therefore people was very disappointed with rapastinel. However, very recently, some researchers suggested that probably this is due to a stratification of the subjects. So if the post-cellular mechanisms are different, some patients may benefit from rapastinel, some patients not. If we can understand in advance which are the patients that benefit from rapastinel, could be a very interesting treatment option. This is another point that is again a completely different perspective. You know that the traditional antidepressants block the serotonin transporter, and then you have the antidepressant effect after 3 or 4 weeks. Well, the problem is that it is believed that the block of the serotonin transporter is blocked by a servo mechanism, a feedback mechanism of the serotonin 1A receptor. So you block serotonin transporter, increase serotonin, but this increase of serotonin creates a feedback that serotonin decreases again. And this is why some people say that we need 4 weeks to have an antidepressant effect. Indeed, we already knew this point. This is why I put our old paper of more than 20 years ago. And at that time, we tried to use pindolol, that is a blood pressure treatment that goes, by the way, on the serotonin receptor 1A, thinking that if you use pindolol, block the serotonin 1A, you have no feedback and you have a more rapid antidepressant effect. Indeed, we had some interesting results in this direction. After it was not much used because pindolol is not very practical. You have to give 3 times a day and it lowers the blood pressure, so it's not the ideal treatment. But this concept has been taken very recently by these other scientists in Science, by the way, published very well last year, where they found a way through the nitric oxide. If they modulate, block the nitric oxide, they can block the feedback of the serotonin system. It seems from this model in a very efficient way. So you can have a very rapid effect of the conventional antidepressants. You don't need new antidepressants. The conventional antidepressants combined with this feedback modulator, they work very well. This is in animals. So let's see if it can translate in humans. So it can change the effect of the normal antidepressants for being 4 weeks into few days. Let's see if someone can develop this in humans. One of the final future possible treatment is the monoclonal antibodies. Probably you heard and you are familiar with the fact that in cancer we had a lot of positive results with monoclonal antibodies. We can target the cancer cells and have a very relevant positive outcome in many cases. So some people thought, why can't we do the same in depression? Why can't we target with specific antibodies the depression mechanisms? And indeed, the theory is there because there is a lot of evidence that inflammation is an issue in depression, that cytokines, some interleukins are relevant in depression. And there are a couple of studies of specific antibodies that block specific interleukin in humans. The few results that are there are indeed very interesting, as you see from the benefit that has been shown compared to placebo. I think this is interleukin 17, but I'm not sure. Also, Maurizio Fava from Harvard worked on this. I'm indeed a little bit surprised because after the initial enthusiasm a few years ago, I found no follow-up on this, but probably people is working and results may come out in the future. The last slide that I wanted you to see is about another complete different mechanism of action. We will discuss also in the next presentation that is more linked to metabolic issues. This is a paper that we are just finishing now about the microbiome. Microbiome, as you know, is the amount of bacteria that we have in a gut. And these bacteria are very important. They can modulate a lot the neurotransmitters in the brain. And some evidence is there that they can modulate also mood, anxiety, inflammation, and therefore, we were wondering which is the relationship between microbiota and depression and antidepressant treatment. We have no time today to go into details. However, the relation is there. The microbiota is related with depression. It is modulated by antidepressant. And to make a long story short, if we can modulate in an appropriate way the microbiota, you have the possibility also to change the mood of the patient and the patient. Still, we are working on this. It's not clear how, but probably it will be possible. So, all of this you will find in a new paper that will be published soon. And this is my last slide. The conclusion of this presentation is that these are very exciting times. After 30 years of having only the usual serotonin reuptake inhibitors or something similar, now we are having a lot of new mechanisms of action for antidepressants that are rapid, that are effective, that are probably even better tolerated. I hope that soon they will be in the market to be used in our everyday clinical practice. Thank you for your attention.